Hello, my name is Richard Corbett. I'm a consultant nephrologist at the Hammersmith Hospital. And thank you for clicking on this video as part of the PD Academy series. I'm going to be talking briefly about smoothing the patient pathway and how to support patients onto home therapies, and particularly peritoneal dialysis. I'm going to use a couple of vignettes for patients to illustrate some cases, an opportunity for you also to think about your own practice and where you work. So a question I'd start with is, what would you want to do if you needed dialysis, or what would you recommend to your patients in terms of an appropriate therapy? This has already been approached with a study from about 10 years ago, asking a large number of nephrology professionals, both doctors and nurses, about what they would offer if, as the best initial dialysis treatment for a patient who could have a planned start either today or in the near future. Within Western Europe and really across the world, almost half of people would recommend peritoneal dialysis or in one of its modalities. If we look at what patients want, there's a very good study from the a Canadian group who looked at a large population who were assessed for PD and hemodialysis. They identified a small group, well, a majority, who would be eligible for both, though you could argue that that is an over strict definition. And I know that one of my colleagues is talking in one of the other videos about suitability for peritoneal dialysis. But even within that tightly defined group, 46% of patients who would be considered suitable or eligible for peritoneal dialysis chose it when provided with adequate information and given comprehensive supportive advice. But when we see figures of physicians and healthcare professionals recommending peritoneal dialysis and patients choosing that between 45 and 50%, we see that this is not what happens in reality. And this is the UK renal registry data from a five-year period within the last decade, and that suggests that at 90 days, around 20% of patients starting onto PD, about half that who would want, and half that who we might think could be offered it and would benefit from being on peritoneal dialysis. And we see therefore a gap between patients starting and patients' wishes or clinician suggestions about what to do. Within West London, peritoneal dialysis historically had a very low take-up, and I'm going to use some of the cases and some of the experience that we've had from locally discuss how we've supported an ongoing and continued growth in peritoneal dialysis in the last 5 years. But I wanted to start by thinking about two patients. The first one is RP, and I hope these patients may be stories that you recognize from your own practice, and I want to use them to illustrate a point. So RP was 55, unknown cause of CKD, and was being worked up for transplant listing, but hadn't got to that point yet. He had a first initial visit in April 2018 for information on peritoneal dialysis and home therapies in general. And by that point, it was clear a month later that he needed to start dialysis with a urea of 30 and function that was progressing rapidly, and referred to be seen formally by the home treatment team. July 18, the second visit, he'd seen a surgeon who suggested laparoscopic PD insertion could be planned as soon as required. He then required a further visit in August 2018, where he had a one-to-one assessment and a nurse education visit with one of our peritoneal dialysis nursing team. A fourth visit was a further surgical assessment preoperatively. Finally, having on the fifth visit a surgical catheter placed under general anaesthetic, straightforward insertion, and he started training late October and was at home doing CAPD 5 months really after the decision to start, or decision to refer dialysis start, to starting at home, by which time his GFR had gone from 9 mils to 7 mils per minute. So in time, and started in a timely fashion, and started on a planned therapy, which is what he wanted to do, but a significant number of visits. If we compare him with DF, a patient from about the same time and coming from the same advanced kidney care clinic that our previous patient had, he'd seen a low clearance nurse in August, who'd noted that he preferred in-center hemodialysis and he should be referred for an arteriovenous fistula. He never made it to the vascular access clinic, and by 4 months after that, he was symptomatic and was referred for an urgent Tessio. His first visit to the satellite, to the hub center, was February 2019, when he has a Tessio inserted and starts straight onto hemodialysis. And so if we look at those two pathways, we could argue that DF starts without definitive access compared to RP, who has a peritoneal dialysis catheter, but DF's pathway is much simpler. And this is on the side here, we have what's called a quincux, which can be used to illustrate a number of various points. But if we imagine that patients are like marbles arriving at the top of this device, what we need to be careful of is that we're not making patients jump through too many hoops, and each of these is a visit where people decide what they want to do. Because if we're not careful, what ends up is PD or home therapies become a choice over here, a route that's very difficult to get to, and we end up providing too many hurdles for patients who want a peritoneal dialysis to overcome. We contrast the patient who had 5 visits compared to the patient who had 1 and ended up on in-center hemodialysis. So though we might think these are opportunities to educate patients, to support them in their decisions, are we actually providing barriers? And while we may be advocating home therapies, are we actually providing equal access for all patients to get to choose a home therapy? So if we want to try and think about the pathway onto home therapies, Peter Blake in Canada has published and thought about this, and thinks about steps to optimize incident peritoneal dialysis. The first step is identifying patients. The second aspect is assessing the suitability. 3, making sure people have an opportunity to have choice, arranging access, and then the start onto PD. And we're going to go through each of those steps. And I think you might want to reflect about your centre and where you see the problems on this pathway as we go through this. So this could be a centre that is thought to be doing well, and that's with 33% of its inpatient, its planned patients who start on RRT at 90 days, a third starting onto peritoneal dialysis. So, for instance, if you model this, we identify all patients, and we believe that most patients are actually eligible for PD. And I think eligibility for PD is perhaps a slightly archaic term, but we can support most patients to undertake a therapy at home if that's what they wish. 80% of the total number are actually defined as eligible and offered peritoneal dialysis. If we accept, as we have that data from the beginning, that half of those choose peritoneal dialysis, we can see that 92% of those who've actually had PD catheter start on peritoneal dialysis. There will be an attrition rate at all of these steps because something happens. For instance, acute illness occurs and people start on in-center hemodialysis as an unplanned start, or there are problems with PD catheters. So you can see this is an evidence, a simulation of a pathway that might be working well. Equally, there are centers where there may be problems with parts of this pathway. So one of the greatest barriers, and we'll talk about that in a moment, is surgical access or laparoscopic access, or indeed local anesthetic access for catheters. If, and this is compared to the center we looked at just now, this is a center that is identifying, assessing, and offering peritoneal dialysis to as many patients as it can and is working well. But if you run into problems with general anesthetic or catheter insertion steps, you can see that you go from having about a third of patients starting onto peritoneal dialysis to about a fifth, and that may be a reflective problem that you recognise from centres. So just take a moment possibly to think of what are the problems in your unit in supporting patients to choose peritoneal dialysis. When it comes to identifying patients, the question is, are all patients being considered for peritoneal dialysis? Are you offering to all those patients who could possibly undertake a home therapy the opportunity to do this? And that really means thinking about patients who start with an unplanned start, people who thought to have an acute kidney injury that tips them into established renal disease. That doesn't mean that they need to start acute peritoneal dialysis, and Hugh Cairns will be talking in another video about the delivery of acute PD, but it may be that they have an opportunity to meet and discuss a home therapy within the first month or two of starting on to hemodialysis. Have you ensured that you're offering peritoneal dialysis to all those people with failing transplants? There's no reason not to offer peritoneal dialysis in this setting. And for those people who are coming in from other centres, have they been offered PD as well? Are you thinking about ways to support referrals across modality, particularly from transplant and those people, those hemodialysis units? And it's really important when supporting patients who've perhaps started on the wrong therapy, or for whom hemodialysis is not what they wanted, that there is an opportunity to identify these people with hemodialysis units, hemodialysis nurses at the patient bedside, really before residual renal function, residual kidney function is lost, and makes the delivery of peritoneal dialysis harder. As I said, there'll be a talk elsewhere about suitability and eligibility for peritoneal dialysis. We often talk about barriers to peritoneal dialysis, contraindications to peritoneal dialysis. We very rarely use the phrase that there's a contraindication to hemodialysis. And though there are difficulties in patients for whom supporting either therapy is difficult, we often place peritoneal dialysis and home treatments in general in a special box. So I suppose the question is, when you think about a patient who has a contraindication, is it really a contraindication to peritoneal dialysis? There are barriers that can be overcome. Use of extended catheters, and surgeons who've got experience of placing pre-sternal catheters in the very obese, and assisted peritoneal dialysis should be available within your centre for patients who are either starting and want to start on home treatment but need support, or who become frail on dialysis. The key thing I would suggest is that suitability assessment, in what I've termed to as a one-to-one in the beginning of this talk, shouldn't be a barrier in itself. What you don't want to be doing is insisting that every patient who wants to have home therapy has a suitability assessment as part of that. Every time you place a barrier, it makes starting onto home treatment harder. You want to do as much as you can, as the title of this talk suggests, to smooth that patient pathway. The other thing is, we should think about is whether we're really offering choice to patients, and supporting people in an even-handed manner to choose what they want that works well for them. It's good evidence where home therapy is pushed, more people use it, and even in the very elderly, where modalities such as assisted peritoneal dialysis can support people to dialyse at home. We often talk about offering choice. We talk about offering choice in vascular access. We offering choice about dialysis modality treatment. But sometimes we need to nudge people, and I would suggest in an area where home therapies are not taken up as much as they should, it may be by nudging them. And to use that to demonstrate why that's the case and why this might be happening within dialysis decision making, I'm going to take another example from another area, and this is seriously ill patients completing advanced directives. And though many patients would want comfort-oriented care rather than life-extending care as default, most patients would default to an option that was pre-ticked in their decision-making. And so if you nudge people by suggesting a decision is already made and people need to make a positive decision away from that, that nudging can make things very difficult. And so we very rarely offer hemodialysis in centre or peritoneal dialysis at home in equal terms. And indeed, it may be that rather than pushing choice, you need to support people or nudge people to make a decision in that right way. And this is reflected in an NNKF DOHI conference from 2019, where I think the last statement is helpful to consider, where if we really want to support people getting to home and really want to expand the number of people on home therapies, then we as units and as physicians and clinicians, nurses, allied health professionals need to undertake a systematic change in how we approach supporting patients in dialysis therapy initiation, and also at an economic level, think about how we provide and support incentives for people for units supporting patients dialyzing at home. This is data and evidence from Birmingham, where there has been is one of the highest performing centres supporting a large number of people onto peritoneal dialysis at the start of dialysis, over a third of patients there. And they highlight that there are some very important steps in this pathway that really informing high quality information, the importance of peer support and people within communities who are on peritoneal dialysis already, supporting communities, particularly where information may be harder to reach and English is not the first language. Talk about education days, again using peer support, and really allowing ample decision-making time, and focusing on shared decision-making about features that are important to individual patients rather than a one-size-fits-all. Now, I'm by no means advocating a PD first process, but you can see that if you were to switch to a system where you mandated peritoneal dialysis the first modality of choice, these are the sorts of figures you'd be ending up with. Probably about 70% of people may end up in peritoneal dialysis. Now, that's not necessarily offering choice as well, and if we really believe in offering choice, that should be even-handed. But this is a model of where PD first might be. I'd argue that the biggest problem, and you will probably recognize this from your centre, that the biggest problem is arranging access. I'm very fortunate. I work with some fantastically motivated transplant and surgical colleagues who are able to put in not only general anesthetic catheters, but put in advanced catheters with advanced laparoscopic techniques, including extended catheters, as well as having myself and two other colleagues who place catheters under local anesthetic. Very few centres have that ability, and responsive catheter insertion is really important to help support the growth and get patients onto peritoneal dialysis. If you can ensure that patients who are referred for home treatment can have a catheter placed promptly, quickly, with minimal number of visits as a preoperative assessment, then you will see larger numbers of patients engage in a treatment they want. But that requires engaged surgeons, but actually also engaged anaesthetists. These patients are often, as we know, multimorbid and require anaesthetists who understand the importance of supporting patient choice and getting patients on a home therapy where possible. And it also requires theatre time, and that, particularly in the COVID era, has been difficult. But what we've managed to do within our centre is prioritise these as life-saving and as tier 1 surgery, because this is an important modality in terms of reducing patients' exposure to COVID from in-centre hemodialysis. And on that basis, we've managed to prioritise general anaesthetic theatre time for our patients choosing peritoneal dialysis. And these are some of the features that may help support patients onto home therapy. And finally, one of the other barriers where people run into problems is that start. Once you've got an access, it's having enough resilience and flexibility in your training capacity to support those fluctuations you see by month, when you have 6 people starting one month and 14 patients, or 0 patients starting one month and 5 the next. Being able to smooth that fluctuation out and keep patients progressing towards care at home. And one of those features is clearly having good contact and good integration with your local clearance teams. And one of the things that Edwina Brown and I find works locally is to think about incremental regimes, not allowing acute. Obviously, we don't want to start people earlier than needed, but a timely catheter placed as people start to become uremic, or before that stage, and then starting people on incremental regimes, so that people aren't starting on a full 7-night APD regime, or starting on a full 7-day CAPD regime, starting 3 bags 5 days a week, or other incremental regimes, or even where people start to get into the habit of dialysis and also can continue that for an extended period of time. And what one also needs is a responsive surgeon, a responsive service able to deal with catheter problems where those arise in the immediate postoperative period, or in the first month or two, when that frustrating catheter that just isn't working properly can be dealt with promptly before people require in-center hemodialysis, lose residual kidney function, and never can return to their desired home treatment. So I finish with a picture of Victoria Falls. And I suppose what we're trying to do here is help support people, get people as easily as possible from this position through here and then flowing down a river. Thank you for tuning into this video, and I hope this was helpful.